Hey, hi students. I hope you can all hear me well and good afternoon. I hope you're all preparing well for your exam. INICET is here and I'm very sure that this exam is that one exam which is going to give you the confidence that you've done a very good exam. This is that place where you have very easy questions, quite a few questions which make you feel that yes, you read well and you could answer everything nicely. But eventually what happens that the few tricky questions, they are the ones which will decide the rank. So don't take any question very lightly because they're not very trick questions. They're testing your basic understanding of the subjects. But there will be a few trick questions. In fact, they are very happy asking you a lot about, in Gynae, I can say a lot about the etiology of PIH. So if you've not read that, please read that very nicely. And the PPH is the hot shot favorite topic for all students who are going to write the INICET exam, any exam for that matter. So yes, let's get going and yeah, I think I can see myself in the YouTube chat. So let's start immediately with the first question, guys. So I'm going to take a few questions which have come in the recent exams and also the ones which are expected topics. Let's see how much we can use this time which we have. So yes, of course, the grant tests are on from PW MedEd, and these are the conditions where we have this real exam simulation. You can predict your scores. You can see how much you stand in the rankings, and of course, you will definitely find out what are the weak points, and we can increase your accuracy when you are regularly doing these GTs. So please do attend the GTs, right? So let's go with the basic questions which we have. What is the minimal number of prenatal visits? So, I did not write India or WHO or the ideal visits because what happens that all of us keep getting confused by what WHO is saying. Look, we have a lot of respect for WHO, but WHO comes in only when the Indian ministry, the Ministry of Health and Family Welfare, accepts their guidelines into our system. WHO is a big body, it has got the whole world to take care of. So there are a lot of countries who are not so well off. India is doing pretty well in the healthcare setup, and we have a lot of hospitals and we have a lot of doctors. So many thousands of doctors like you are trying to get into the system and take care of the patients. So not all what is written by WHO becomes a law for us to follow. Latest WHO guidelines and latest UNICEF guidelines and latest American College of Obs and Gynae guidelines, they don't make sense. Please, till they are accepted into our system, into our medical colleges. So don't get too perturbed if you're, sir, the guidelines have come, recent guidelines have come 15 days back. So nobody's going to ask you those in the exams. They'll ask you what is the basic practice of all the 19 subjects, especially the cleaning subjects. So right. So I'm telling you what is the prenatal visits, the minimum number of prenatal visits. When we say India, we should say at least 4 visits. Okay. So minimal prenatal visits, at least this much you should do. You must have at least 4 prenatal visits. So yes, that is the answer here. So I'll just tell you here that once, if you say ideal number of visits, if you're saying that this patient is coming regularly to the clinic and this patient is going to listen to everything what we are saying, that kind of patient, then we can have once every 4 weeks till the 28 weeks. All right. So that is around 7 visits will be there, 7 for the 28, and then 2 weekly from 28 weeks onwards. So let's say from 28 week onwards, there'll be 1 visit on the 30th week, 32nd week, 34th week, and then the 36 weeks. So that will make 4 visits, and then weekly once afterwards. So after 36 weeks, there are 4 weeks left. So you can have maximum 4 visits after that. So you will generally have patients delivering in 38 weeks or 39 weeks. They can go up to 40 weeks also. So you will have something like 2 or 3 visits there. So that's why we say the ideal results are 12 to 14, because some patients will deliver at 38 weeks, some people will go till 40 weeks and deliver. So every week they should come. So this is what is ideal. This is what we should be doing ideally. But yes, excuse me. But if you say WHO says that there should be 8 visits. Now, this is there in so many of your sources that I must tell you about WHO also. So, first trimester, they say there should be at least 1 visit in the first trimester. There should be at least 2 visits in the second trimester. And there should be at least 5 visits in the third trimester. That makes total 8 visits. And what happens in the Indian care system, that yes, our women from the village are not going to listen to us so much, and they're not going to come regularly. We say at least you come once in the first trimester and once in the second trimester, because first you come in the first trimester, we'll see if the pregnancy is the right location, we'll see whether you're having a proper growth of the baby, and is there any other problems. We should give you the, after you're in the first trimester, we'll give you the folic acid supplementation. And then if you come once in the second trimester, we'll do one ultrasound and see the anomalies. If you come on that one visit at least, and we'll give the immunization. If you don't come again, at least once you should come. And then in the third trimester, you should come twice. So that is 4 visits in the Indian healthcare system. So that's what was asked in this question. How many visits at least? Right. So after knowing this, let's go to the next question. A lady presented with complaints of foul-smelling grayish-white discharge. Foul-smelling grayish-white discharge, and a whiff test done on the discharge was positive. Whiff test was positive. Now, look, these infections, they're very fond of asking vaginitis, especially INICET and the MSA exam. So please do not miss out on these. They will always ask you. So I'm asking you that there is a whiff test positive. You know what's the whiff test? That in the secretions, if you add potassium hydroxide, you'll get ammoniacal whiff, ammoniacal smell. And on examination, the clue cells were seen on the microscopic examination. What is this condition, and what is the drug of choice for treatment? So clue cells. Now, this is that very important thing. The clue cells. I don't know. This is that one question. I think it's and has to enter into the genome of all the medicos which are becoming doctors, because you must know about these clue cells. It is coming in almost, there are 5 exams in a year. It comes in at least 2 or 3 exams. So yes, clue cells are seen. So this is definitely bacterial vaginosis, also called the Gardnerella vaginalis, causing the bacterial vaginosis, and the drug of choice is metronidazole. Remember, metronidazole is safe in pregnancy. It is safe in pregnancy. It's a category B drug. It's a category B drug, and we can safely give it in the first trimester also. If they ask you what is the drug of choice for bacterial vaginosis in the first trimester, we can go ahead and give bacterial vaginosis management with metronidazole. So I'll just show you the clue cells. Yes, clue cells are the vaginal epithelial cells which are embedded with a lot of bacteria. They'll be studded with thousands of bacteria. So these are cells which you see in a pap smear also. Same cells, right? The vaginal epithelial cells, the cervical epithelial cells, they all look the same. So when you see these cells, they will be embedded with thousands of bacteria. So that is what is giving us a clue that yes, this patient is going to probably having bacterial vaginosis. Those are the clue cells. And then you'll have the, yes, these are the cells which, these are the organisms which you see in trichomoniasis. I thought I'll just show you all the pictures. Trichomoniasis. In trichomoniasis, you see the trichomonads. These are the trophozoite forms. These trichomonads have these flagellated parasites, and they'll be moving around in the vagina. They're not very small. They're 30 to 40 microns in size. So when they keep moving around in the vagina, they cause a lot of inflammation and a lot of irritation, and that's why the inflammation makes the vagina red. So vagina, colpos, vaginitis, colpitis, and they're red macules. So we also call it colpitis macularis, which is basically the strawberry vagina and the strawberry cervix, which you see. Please, if the vagina is having a strawberry kind of pattern, the cervix will also have the same pattern. Don't think that if the vagina is strawberry, the cervix will be mulberry. Please, this, I don't know why you guys keep getting confused. So vagina is strawberry or the cervix is. I get this question so many times that now I'm trying to be a little funny here, but please, vagina and strawberry, everything will be having the same pattern. Strawberry vagina or colpitis macularis will have the red macules. All right, guys, let's move on and see. Yeah, now I've given you all of these together. Please, I'm giving you all of these together so that in every discussion, every test and discussion, I'll give you this slide. Please pause this and read this, because this will come in the exam. I'll just quickly remind you, when in bacterial vaginosis, the most common vaginitis, and the Gardnerella vaginalis, Haemophilus vaginalis is the causative organism, and there are 5 criteria known as the AIIMS criteria. 3 or more out of these 5 are the diagnostic criteria. At least 3 should be there. What are the 5? Alkaline pH, creamy white discharge, fishy odor, whiff test, and the clue cells. Any 3 of this is the criteria, and only the woman needs to be treated in bacterial vaginosis. There is no change in this. Please don't say that these are straight away facts. There's a lot of research coming. A lot of people say it's better to treat the husband also. Look, till it is in a book, I'm not going to tell you to change your answers. Okay, it is not there in any book. I'm waiting for the latest editions of the books to come out, and if they are telling It is accepted by the Federation of Obstetricians and Gynecologists, accepted by the world bodies, and it is there in all the books. I will come and teach you something new. So far, bacterial vaginosis, please treat only the woman. It is not sexually transmitted. Yes, trichomoniasis, you must treat both man and woman. Of course, the drug of choice, there is also metronidazole. And I told you colpitis macularis and strawberry vagina there. And in candidiasis, it is in acidic pH. It's a dimorphic fungi. Remember, she also has a lot of itching, and trichomoniasis has a lot of itching, but there is no pruritus. There is no pruritus in the case of bacterial vaginosis. So we are not changing these, the main features which we are teaching you. We're not changing them as of now, right? And remember, there is something called complicated candidiasis, which is by non-albicans species. Non-albicans species are like the Candida gibraltar, Candida tropicalis. These are the species which are difficult to treat. They are very recurrent and seen in immunocompromised hosts. I hope I'm not hiding something. Yes, maybe the last line I've written here is the immunocompromised host. So that's about this. A lady with infertility. Are you asking me some questions? Let me see what you guys are asking me. Let me have a look. Wait, let your question go up a little because I'm not able to read it completely. Okay, guys. We'll take the next question meanwhile. Okay. A lady with infertility undergoes a laparoscopy for the purpose of assessment of her pelvic anatomy. For tubal patency, a chromotubation involves pushing a dye from a cannula into the cervix, which is observed to come out from the fallopian tubes. This chromotubation is usually done using which of the following? Now, this is a laparoscopy. In laparoscopy, we put in a scope into the abdomen. We look at the uterus and we see the dye coming out. One of you guys, my intern friends, are going to put a leech cannula. A leech cannula is what is your, yes, a leech cannula is what is your instrument, which is going to be used even for the laparoscopy when we are doing the dye installation, and even for the HSG when we're doing the dye installation. So leech cannula, we can also use the Rubens cannula. There's a Rubens cannula also, but one of these cannula is used to put the dye. And when we're doing laparoscopy, we can see the dye with the, with the eyes, we can see the color of the dye. That's why it is the methylene blue. Okay, we use the methylene blue. Do not get confused with hysterosalpingography. When we ask you hysterosalpingography, a lot of you in a hurry will mark on methylene blue. In a hysterosalpingography, it's a radiopaque dye. It's got no color. Okay, so please, this is what you see in a patient when we're doing a, yes, can you see? That is what is a color of the dye. I was doing the laparoscopy and somebody instilled the dye. Can you see the dye came out only from the left side of the tube? Okay, it did not come in the right side at all. Yes, once again, yes, see, dyes come out from the left side, the methylene blue, and it's not come out from the right side. So this laparoscopy, why do I say laparoscopy is the best method of assessing the anatomy of the lady? Because while I'm doing the laparoscopy, I can see what is wrong, and I can see the relation of the tube with the ovaries, and I can see there is any endometriosis, tuberculosis, and I can remove the adhesions. And if the tube is blocked, like in this case, the right tube is blocked, so I did a hysteroscopy in the same sitting. And when I did a hysteroscopy, I did a cannulation of the right side. And after that, we did a laparoscopy again. The tube got opened and this lady conceived. This is around 4 years back laparoscopy. And the patient conceived. She has a child now because the tubes are blocked. So yes, maybe this procedure opened her tubes and she got conception. So that's why we say to assess just the tubal anatomy and tubal patency, we can do HSG. But it's a highly incomplete investigation. So when we are infertility specialists, we don't bank on HSG too much. We bank on a laparoscopy, which gives us the complete information. So if they ask you the initial test for the assessment of the tube, you can say HSG, but it is highly incomplete. It tells me only about the tube and the uterine cavity. It doesn't tell me about the relations. And if the tube is blocked, anyway, you have to do a laparoscopy. So that's why I'm not saying it's a redundant investigation, don't get me wrong, but it's a good preliminary investigation, the HSG. The best is the laparoscopy and the hysteroscopy. So yes, that is the HSG, which you people have seen. See, I'm instilling the dye. This is the leech cannula again. And when you see the uterine cavity, then you see the fallopian tube. Yes, you're not seeing nothing else. You're not seeing the tube over relation. This patient actually had a dermoid cyst and she had a lot of adhesions. She's also conceived. This is around 3 years back. She's conceived. She has a child. But after this, also, when she didn't conceive, we did a laparoscopy and we took out the cyst. We found so many adhesions. And that's why we say that it's better that we should be doing a laparoscopy than a hysteroscopy for the complete assessment of the anatomy, right? So Astosh Kumar, we should treat candidiasis. It's only vaginitis, and I would treat candidiasis by local antifungal drugs. Right. If you want to give a blanket therapy, something called the gunshot, what do you call that? Gunshot therapy. That is, you give all the antibiotics to all the patients who got anything like a vaginitis also, then that is not a ideal kind of a treatment. Okay. You cannot give empirical treatment for everything. When you have candidiasis only, treat that. Of course, there could be coexisting infections. You look for them, right? We will not just blindly give all the antibiotics. So that's what happens. Why do you think we are having so much of antibiotic resistance in our country? Because a woman having just candidiasis is given treatment for the trichomoniasis also. She's given treatment with cephalosporin for the gonococci if it is there. And she's given doxycycline also if at all there is coexisting chlamydia, because candidiasis hoga to sab kuch hoga. That is a logic which, that beats logic rather. That beats logic. So I don't want you guys to fall for these traps. You're going to be ethical doctors. You're going to be diagnosing the appropriate infections and then give the treatment, right? Okay. So for the diagnosis of Mullerian abnormalities, good Himanshi Kumari. Yes, for the diagnosis of Mullerian anomalies, the best is a laparoscopy and the hysteroscopy in the same sitting. MRI is the best. Imaging. In imaging, what do we do? We can do an HSG. Imaging matlab radiological procedures. We can do HSG, will tell us about the uterine anomalies, Mullerian anomalies. Ultrasound can tell us. 3D ultrasound is fairly good. Most people, radiologists are like, what is the need of doing anything else when we have a 3D ultrasound? They're so happy with the 3D ultrasound. But we have got a lot of wrong diagnosis on 3D ultrasound also. So best in the imaging, best in the radiological procedures is the MRI. But overall best is the laparoscopy and the hysteroscopy. There's nothing which comes close to looking at it with your own eyes, right? So that's why that is the best. So good question you asked me. Let's move on. Again, this is the same leech cannula which I was telling you. Okay, let's move on and see another question. Seminal vesicles and vas difference would be bilaterally absent congenitally in which of the following conditions? So congenital bilateral absence of vas difference, CBAVD. This is for us infertility specialists. This is like straight away. When it is there, rule out cystic fibrosis. That's what has, engraved into our genomes. Yes, it is. Always think in terms of cystic fibrosis. It could be some other reasons also, but cystic fibrosis comes first in the list of our probabilities. So go ahead and mark cystic fibrosis. Klinefelter's is, of course, 47XXY. Yes, that is 47XXY. Kalman syndrome is a hypothalamic. It's a hypothalamic problem, that there's a hypothalamic problem, that is hypothalamus not working. Along with that, there's no stimulus to the pituitary. Obviously, there's no FSH and LH to stimulate the testes. And cartilaginous syndrome is the immotile cilia syndrome. You know this very well. But cystic fibrosis, I want to just tell you something. Cystic fibrosis has the CFTR gene deficiency, which is the cystic fibrosis transmembrane conductance regulator. Now, it is an autosomal recessive inheritance. So, what happens? This patient will have 97 to 98% chance that the vas will be absent, although the production of sperm is normal. So it's very simple treatment for us. If the vas is absent, but the LH and FSH is normal because the testicular production of sperm is going on. So LH and FSH will be normal. So I see a man who's got azoospermia in his semen analysis. I do the FSH and LH. It is normal. That means there's a high likelihood that the testis is making the sperm. So what do? I put a needle into his testes or into his epididymis and aspirate the sperms. And those sperms, I'll put them directly into the oocyte of this lady, of the wife of this gentleman. And when we do that, that is known as intracytoplasmic sperm injection. That is the answer. We've given enough pregnancies. And now you'll think that there will be an inheritance. Yes, if the father has it, if this father has it, then this is an autosomal recessive condition. The child will be at most a carrier. Okay, so hoping that the future partner of this person does not have the recessive gene. So at most the person will be a carrier, right? So you can go ahead and do ICSI and give. Lots of people with bilateral absence of vas difference have had children without any problems. Of course, they have to go through us after that. So yes, there is a transportation issue, the vas being absent, and of course there could be a low volume associated. I forgot to tell you that the volume, if it is less, it will be less. it'll be something like, because seminal vesicle is absent, right? So seminal vesicle is not there, vas is blocked. So semen, what is semen? Semen is 70% seminal vesicles. So if that is absent, vas is, I'm so sorry, the seminal vesicle is absent, so the volume is less. So when the volume is less, one more thing, fructose. If the semen analysis is showing you less volume and no fructose, this is a question. It came in NEET exam. Where do you look for the block? Seminal vesicle blocks, right? Chalo. What is, that's a good question somebody is asking me. So, what is the difference between, wait, don't read the question. Okay. What's the difference between vaginitis and cervicitis clinically in syndromic management? Is the two different for vaginitis and uterine discharge? See, in the syndromic management, if there is a person with a white discharge, we go ahead and give the kits. Yes, we go ahead and give the kits because syndromic approach is not for the ideal clinical setup. When you have a good clinic where you can do diagnosis, then you can go and get the syndromic approach. I'm not against the syndromic approach. When somebody has a genital swelling and discharge, then we have a syndromic treatment. When the person has a white discharge and pain abdomen, then we give a PID kit, kit 6 we get. So I'm not against those kits. Those kits are very useful because women in the villages are not going to come to the big hospitals and get a specific diagnosis. You and me are talking about the ideal management systems. So there, I'm not going to say give a blanket therapy to everybody. Syndromic approach is good. I'm not saying, please don't get me otherwise. I'm not saying it is bad, but it's not for the ideal setup where we can diagnose the specific symptoms. Why make her have so many antibiotics when only metronidazole is required for bacterial vaginosis? Why should I treat even chlamydia and even gonorrhea? Why should I treat when it is not existing? A lot of women have trichomoniasis, but I don't treat chlamydia in them because they're having sex only with their husbands. They're not having multiple partners. So I'm not thinking that they're going to, everybody who's having a white discharge is having multiple partners. But when I'm in a setting, low resource settings, where I'm not able to do the, I have a OPD of 300 patients in a small district hospital and there are hundreds of patients and the resources limit me. So I'll go ahead and give those kits. So it depends where and when. So ideal management we are discussing right now. Okay. Of course, your PSM people are telling you the kits, and those kits are given exactly for the purpose which you're asking me. When there is a white discharge and there's a pain abdomen, go ahead and give the PID kit, kit 6. You go ahead and give. Right? I'm not against that, but we are talking about ideal systems. All right. Antepartum hemorrhage due to abruption shows all of the following: abruption, painful bleeding, and plasma previa, painless bleeding. Clear concepts. Okay. It can be coexisting in both. All those gray areas we're not talking. All of your MBBS exams, your PG entrance, and even your MCI entrance, all these exams talk only about black and white. When you do PG, whole life is in gray. What can coexist? What may be the ideal, but what is the patient presenting with? All your life is going to be understanding and managing the gray. That's why you become a specialist in some subjects. So right now, black and white is what you have to know. Okay. So antepartum hemorrhage, painful bleeding. It shows all of the following. It shows uterine, excuse me, it shows uterine tenderness, and it may show frequent contractions. Okay, painless vaginal bleeding, wrong. It is seen in placenta previa, and mild to moderate vaginal bleeding, correct. So frequent contractions, yes, patient is with abruption, she may go into labor also. So I'm not very happy with the B choice, but then yes, it is definitely not a painless bleeding. So we'll go with that answer here. So when you have abruption in a patient, remember outright basics that when there is abruption, there is bleeding behind the uterus. I've drawn red, so I'll have to make the bleeding blue. Okay, so that's a blue blood in this lady. Okay, so there is a retroplacental clot. Retroplacental clot is the concealed bleed, or the blood could come out like this, and it could be a reveal bleed, or there could be bruising in the uterine muscle. Bruising is what is known as the covular uterus. Look, there's so many times they just ask you what is the covular uterus, which condition you see it. That you should know. Bruised uterus, a uterus which is punched. Uterus which is, when you do a cesarean on a abruption uterus, you'll see it'll be black and blue, just like somebody has punched the uterus many times. So that uterus with bruises will not contract too well. So the labor might be protracted. In even after delivery, she will have a poor contraction. She may have PPH also. Now, wait, PPH can happen in a cesarean section also. So please don't say that when there's abruption, the management is cesarean section. I don't know where you guys are getting that from. hundreds and hundreds of patients in our labor rooms delivered with abruptions vaginally. Okay, no way it is written that if there's abruption, go ahead and do a cesarean. Yes, if there's a fetal distress, I will be the first one to rush the patient to the OT like a maniac and do a cesarean section in 12 minutes. Yes, that's a different situation altogether. But if there is a patient who's got abruption, I will patiently induce labor with doing an artificial rupture of membranes. So I'll do an ARM. I will start oxytocin. I know that ARM will this will increase the prostaglandins, which cause the induction of labor, and it also reduces the bleeding. So when there is abruption, I will do normal vaginal delivery. Please, guys, remember that. Yes, if there is a fetal distress, the distress with abruption becomes the indication. What if the baby is dead? So baby to mar gaya hai. Baby is dead. There's abruption. Baby is dead. So what is the emergency? Is there emergency now? The baby is dead. Worst has already happened. Again, do normal delivery. Baby is alive, abruption, do normal delivery. Baby is dead with abruption, do normal delivery. Baby is dying, having a low fetal heart rate, go ahead and do a cesarean. So it's obstetrics, guys. Obstetrics का मतलब ये नहीं कि everything you do a cesarean section. Get very clear ideas in life. Chalo. What are you guys asking me? Ideally, you should be doing a perspective examination, all right? Imanshi, correct. Ideally, you should be doing examination. Obviously, you should be doing examination. But sometimes there is a medical officer sitting and a medical officer does not know. So kit giving is not a bad idea. At least the lady who's come and the lady who's showing to a medical officer who's not a specialist in gynae can still give the kits. At least some healthcare delivery is there. Hmm? Ideally, everything has to be done after examinations. Okay, a woman presents at 8 weeks of gestation. Which of the following signs can be elicited at this gestation? 8 weeks is where you see everything. Only Hagar sign is seen at 6 weeks. So that's why 8 weeks you see everything. So what do you see at 8 weeks? You will see the Goodell sign. Yes, that is a soft cervix. Osiander sign is the pulsatility in the lateral fornices. There's the cervix. Put your fingers in the lateral fornices. You'll see that there is a pulsatility in the lateral fornix. And that pulsatility is what is known as the Osiander sign. Okay. So when a patient has the pulsatility or the Osiander sign, and the Goodell sign, that is the soft cervix. These are all at 8 weeks. And even the Shadwick sign, yes, the Shadwick sign, which is the blue cervix. Yes, it is the blue cervix. A lot of you keep getting, no, sir, my book where I'm reading, it is written blue vagina. Look, if the cervix is blue, the vagina won't be yellow. Okay, so the vagina will also be blue. And yes, Shadwick sign can also say a blue vagina. But if you see a Williams obstetrics, it is classically mentioned ectocervical hue. The bluish hue is because it is for the cervix. Okay, so it is meant for the cervix. Of course, the vagina also will be blue. So Shadwick sign, Goodell sign, Osiander sign, all 8 weeks. But yes, the Hagar sign is at 6 weeks. Now, internal ballotment is not at this time. Okay, so Goodell's and Osiander sign is at 8 weeks, 1 and 2. So choice B is the answer here. Internal ballotment, yes. External ballotment is it. There is a head here. See here. There is a head here. See, you hold the head just above the pubic symphysis and tap it like this. Okay. So yes, the tapping of the fluid. My iced tea, sorry. So when you're tapping the head, when you hit with the thumb, it hits the fingers. When you hit with the fingers, it hits the thumb. So it's like a ball. Okay, that is a external ballotment. You can see external ballotment somewhat later, around 20-24 weeks. But internal ballotment can be seen earlier. What is internal ballotment? You put your fingers in the vagina and go and hit the head. Of course, don't go through the cervix. Okay, just go on the side of the cervix. You can feel the head. When you hit the head goes up and comes and hits your finger back. That is an internal allotment. You can see it as early as 6 weeks. All right, guys. So yes. So when we talk about internal allotment, that is not at 8 weeks. Lightening. Okay, it is feeling light. The woman feels light. Why? Because the big head of the baby has gone into the pelvis. She feels light, that she has some space to breathe properly because the full baby is inside the abdomen and the diaphragm is not able to move properly. She feels that breathing is becoming a difficulty as she's growing into the pregnancy. But the moment the head goes into the pelvis, then the biggest part of the baby is gone to the pelvis. The mother feels light. That's just lightening. Okay, feeling light. Lightening is not like thunder and lightning, not like that. Lightning is feeling light. Okay, so Let's move on and see. Oh yeah, I just thought I'll tell you the list of the signs because that also came as a question recently. I think in July 25, I think in the MC exam. What are the presumptive, probable, and the positive signs? So yes, all of these signs which we read with you, the list is there with you. I'm not going to read all of that, but at least I'll tell you that the signs which we discussed, the Shadwick sign and the Goodell's and the Hagar, these are the probable signs of pregnancy. Also something you can write, the Palmer's sign. The Palmer's sign is also here. What is Palmer's sign? When you do a per-vaginal examination in the early pregnancy, like 4 to 6 weeks, you can see some rhythmic, you can feel some rhythmic contractions of the uterus. So that is the Palmer's sign. In pregnancy, you can feel that. There is another sign which is the Braxton Hicks. This is somewhat later, 16 to 18 weeks. That is the feeling of the uterus becoming very hard. The woman will say, my uterus becomes very hard, and it happens every 20, 25 minutes, maybe once in half an hour, she'll say, and uterus becomes hard like a stone, and then it relaxes by itself. But is that something wrong with me? So I will ask her that, is it painful to you? She says, no, sir, it is not painful. So if it is a painless hardening of the uterus, that is classical Braxton Hicks. These are also known as practice contractions. The uterus is just getting into practice of delivering later. So yes, the uterus is getting ready for labor. We call them practice contractions, but these are not painful. Of course, they'll become painful eventually at 37, 38 weeks when the woman delivers. So positive signs, of course, the definitive signs of pregnancy, ultrasound showing a fetus, fetal heart rate via Doppler. See this list when you have time. Okay. So the non-contraceptive uses of oral contraceptives include all of the following except. Now, please, whenever you have time, go and see the oral contraceptive chapter. Suddenly, they have a renewed interest for the last 1.5 years. I'm seeing renewed interest across all the exams in COCPs and their benefits. So, what are the non-contraceptive benefits? So, reduction in the risk of ovarian cancer. Yes, there is lesser ovulation, so lesser injury to the ovary, lesser ovarian cancer. Ectopic pregnancy obviously is lesser. Yes, the pregnancy is lesser, the ectopic will be lesser. There's no doubt about all these things. When a woman doesn't conceive, how will she have more ectopics? So these are all very clear concepts. Lesser pregnancy, lesser ectopics, correct. Protection against sexually transmitted disease, this is not done. So the answer to your question is already here. Colorectal cancer, this came, yes, July 25, this came. Which of the following cancer is reduced? Colorectal cancer is reduced. Breast cancer is not reduced. Wait, I said breast cancer is not reduced. I did not say breast cancer is increased. So yes, Williams offset is very clear, and I'm not changing anything based on whatever guidelines have come from whichever new journal. Till it is in a book, I'm not telling you to change your answers. Please, for God's sakes, don't conceive. Keep confusing yourself. Don't conceive any thoughts which are based only on journals. You know, medicine, overall science. 50,000 new words. 50,000 new words are written every 1 hour in medicine, and you're going to change yourself, your ideas by those 50,000 words which are written every hour. There is no way you can follow them. So till they become accepted recommendations in a system. So yes, if a patient has COCPs for 10 years, 15 years, she's going to reduce the risk of a benign breast diseases. CA breast does not reduce, it does not increase also. There might be a slight risk, some books are saying, even Williams says that, but once you stop the tablet, the risk goes off. So don't say OCPs cause CA breast. Please, for God's sakes, don't say that. And some of you have an idea, so you're giving COCPs for 15 years, you're giving it for 10 years. 10 years we're giving COCPs, estrogen to itne din de rahe ho, you're giving estrogen for so many days. That's why there will be more amount of estrogen, and more amount of estrogen causes CA breast. Guys, please go ahead and see the app. Okay, see the MedEd app. We have taught you nicely about this, that when you give COCPs, you give the least dose of estrogens to suppress the pituitary. The least dose, 0.03 milligrams, so 0.02. There is a 0.01 milligram tablet also. I'm giving the least dose of estrogens to suppress the FSH. And if I'm giving the least dose of estrogen for 10 years, there'll be less estrogen in the body. That's outright basics. So do not get to think that you're giving estrogens for a long time and there'll be a lot of CA breast. So CA breast does not reduce, it does not increase. Colorectal cancer reduces because you're reducing the bile acids in the circulation and the bile acids in the gut. So that's why there is lesser colorectal cancer. All right, what are you guys saying? All right, you guys are listening for the time being. Yeah, that's fair enough. Let's move on and see something else. Consider the following actions under active management of third stage of labor. We are getting into our favorite zone again. Arrange them in a right order. So uterine massage is not the best first thing to do. give uterotonic oxytocin 10 milligrams, exclude the presence of another fetus, and control contraction. So yes, the drill is, moment the head comes out, you hold the head, take out the anti-shoulder. Moment the anti-shoulder comes out, you give oxytocin to the mother. When you give oxytocin to the mother, now the shoulder has come out, so posterior shoulder comes out, the baby comes out, and once the baby comes out, we hold the baby down for a minute, delayed cord clamping. By that time, the oxytocin which you've given will go on getting absorbed in the body, and the peak action will be getting established. So when a patient is given oxytocin, moment the baby's anti-shoulder is delivered, by the time the baby comes out, you do control cord traction, you do delayed cord clamping, then you do control cord traction 5 to 10 minutes, and finally, when the delivery is complete, the peak action of oxytocin is achieved and the uterus will be well contracted. So that's why it is known as active management of third stage of labor. So you will give the uterotonic first, oxytocin is given first, and then you will do, of course, before that you will exclude the presence of another fetus. So yes, I will say first is exclude the presence of another fetus, give oxytocin next, and then you'll do a control contraction, and you'll definitely do a gentle uterine massage. You have to do it. So yes, it is in the order of 3, 2, 4, 1. 3, 2, 4, 1. Choice B is the answer for your question. Guys, we will give a uterine massage. You have to give a uterine massage, gentle uterine massage, because that promotes contraction. Yes, you will not put a hand in the vagina and put a hand on the abdomen and do a bimanual compression of the uterus. That's very painful. So we don't do a bimanual compression. The question which we are discussing, this is an INICET question. Again, this question came, INICET question again. I think that was the December 2024 question, November 2024 question. Again, they asked which of the following is not done, and the choices were oxytocin, control contraction, bimanual massage, or uterine massage, which is not done. So you had to answer bimanual massage. Uterine massage again was there in the exams, and you had to do uterine massage. INICET people are always asking you about uterine massage, and please do uterine massage. Please don't do bimanual compression of the uterus, okay, because it's painful. You know what? We generally do it also, but it is painful. So yeah, I think I'll say I don't do it. But yes, we generally do it. We gently do a little bit of massage because I know I'm giving her a little bit of pain, but that is not ideal. So don't do bimanual compression. But I feel that PPH control is better. So I'll go ahead and give a uterine massage, which is on the abdomen. But I generally, if I see a little bit of bleeding also, I just put my hand inside, and we have given some sedation for the pain, for the delivery. We have given epidural also these days. So I do a bimanual massage personally. I'm accepting online. The whole country is seeing this. Yes, those who are medicos are seeing this. We do a gentle bimanual massage also, because there is some bleeding, the massaging will stop. But I'm not telling you to do that. The recommendation is definitely not to do a bimanual massage because it's painful. But uterine massage is done. Williams Obstetrics is writing that we promote this, we promote uterine massage with the caveat, with the warning that it is not a very strong evidence. Yes, not many people like it, but Williams Obstetrics, the American system, the reference book says they do it. And what does the Indian setup say? What is the Ministry of Health and Family Welfare saying? Turn and see. Ministry of Health and Family Welfare, this is the notice which is supposed to be put in front of all the medical college labor rooms, all district hospitals, all first response units. And what is written there? Oxytocin 10 units IM at the delivery of the shoulder, and control contraction of the delivery for the delivery of the placenta, and uterine massage to keep the uterus contracted. So when my ministry is saying do a uterine massage, I'm not going to listen what WHO is saying. WHO is a good body, God bless. They are the ones who are taking care of health all across the world. But we guys are better off. We have enough doctors to be in the labor room and give a gentle uterine massage, not bimanual. Okay, fine, just only on the abdomen. Okay. Yes, I want you to see one more thing. Same poster, I'll just magnify some bit. What is written here? For use in medical colleges and district hospitals and first response units. Yes, that's what they're all medical college. You'll see this. Yes, this is supposed to be there by the government of India. That's a direction, right? So I will rest my case here. You will have to give uterine massage. In PPH, we don't do bimanual. No, we don't do bimanual massage. Okay. Mm. Dr. Alam, please don't get scared. OBG for INICET. Look, INICET is an exam which is a good, easy exam. It is about the basics and a few difficult questions. So INICET is suddenly somebody who feels he's done a decent reading, but he's not the topper of the class, but suddenly that guy does very well because he's done the basics well. INICET is a surprising good exam, and it is that one exam which I feel that even students who have started reading only for the last 3 months to 6 months will suddenly show a result and they'll get a good rank in INICET. It is that exam which is outright basics, few difficult questions, and if you do them, you'll get into the system, right? So bimanual massage is not done, uterine massage is done. All right, what I said, what I do in my practice is not to be followed. You will say uterine massage is done, but not bimanual compression. A 6-year lady with the uterus protruding out 10 centimeters, which of the following is the best treatment? So if there is a uterovaginal prolapse and in a 60-year-old woman, so we will not repair because she doesn't have the need of the uterus. So we go ahead and do a hysterectomy. Now, when the uterus is hanging out of the vagina, there's no point doing a abdominal procedure or a laparoscopic procedure. It's not there in the choice also. Yes, abdominal hysterectomy is in the choice. We'll not do that. Pessary treatment is a temporary. It's a temporary relief, and Leaford's partial colpoclesis. I'll tell you that the answer is vaginal hysterectomy and a pelvic floor repair. Look, if you do not repair the floor, see if you see the if I how do I go to show you that? Okay, fine. If I show you the uterus with this bag here, okay, say this. This is the floor of the floor of the pelvis, the levator nine. This is the vaginal opening, and the uterus is coming out of that. So this uterus is coming out of that. What do? You do a hysterectomy. The uterus is out. But can you see this vagina is so big and wide? So you have to make the vaginal opening back to the normal size. So basically, vaginal opening is a defect in the pelvic floor. So when you're repairing the vagina, you're basically doing the pelvic floor repair. So when you do a hysterectomy, do a pelvic floor repair so that whatever else is there, the bowel and the bladder, there should not be a cystocele coming out. There should not be a rectocele coming out. Bowel, okay, enterocele should not be coming out. That's why you should do a pelvic floor repair. Okay, so Leaford's partial colpoclesis is that there's a big vagina through which the uterus is coming out, then you make it a double barrel vagina. Okay, you will do a partial colpoclesis for old debilitated women who cannot withstand a major surgery. So she's around 89, 90 years, and if she has a prolapse and she's not got it repaired, and now the surgery itself is a risk for her, she may die in the surgery. So you just do a local anesthesia and do a partial colpoclesis. That's very much lesser of an operation. So yes, what is a vaginal hysterectomy? Now let me see if I can explain that to you here. So when this, you can see the anti-abdominal wall here, the bladder here, the uterus here, the green thing is the peritoneum, of course. And when the uterus is going out in a prolapse, yes, you will see the bladder is coming out here and the rectum is coming out here. Obviously, that's why there is a urinary problem, there is a defecation problem because of this, because the bladder is hanging out. So what do? You push it back inside with the pessary, good temporary treatment. Now, when you do a hysterectomy, when you take out this uterus, see, I'm going to take out this uterus. So this peritoneum which is attached is going to come out also. See this? This is how it looks. When you do the hysterectomy, this is the peritoneal edge here, and then this is the vaginal edge. Once again, see, this is the uterus. This is the uterus which I'm going to take out, and the peritoneum on it also will come out. So that's how it looks after the surgery. Now, you will close the vaginal defect and you will do the anterior vaginal repair, vaginography, or vagina is also called colpos. So we do the anterior colporaphy. Then you'll do the posterior colporaphy, okay, posterior vaginal repair, but there is a perineum also behind, so we'll do a posterior colpoperineoraphy. So anterior colporaphy, posterior colpoperineoraphy. These together, okay, these together are known as the pelvic floor repair. I'm not saying that you have to do both to call it pelvic floor repair. You can do just the anterior colporaphy, that also is pelvic floor repair, because sometimes people don't have a rectocele. If both are present, you do both. So now please don't lose the connection with the topic. Anterocolporaphy, posterior you close the vagina. Don't you think the bowel will come and hit this vaginal vault, and she'll also have a vault prolapse? She'll have a vault prolapse in a few days because of the bowel loops. So that's why we will hold the bowel here. We'll hold the bowel here by doing a high ligation of the peritoneal defect. So the bowel will stop here and not come up. So that's what is known as a cultoplasty. We call it the McCall's cultoplasty, or we call it the high ligation of the peritoneal defect so that the bowel will be stopped by the peritoneum to hit on the vaginal wall. So pelvic floor repair plus we also do the ligation of the peritoneal defect, which is known as a enterocele prevention. Because when we do this, when we stop the entrum, the enterocele to hit the vault, there will be no vault prolapse. What is the major cause of the vault prolapse? Vault prolapse, the vault, which is the vagina after the hysterectomy. The most common cause is the neglected. It is the neglected enterocele. So yes, don't neglect it. Do the highlighting of the vaults. Right. So what are you guys asking? 60 is not too old. 60 is all right, man. 50 to 65 is middle age, man. What's wrong with you guys? In fact, it's 60 to 75. After 75, we call old. Okay. 60 is pretty young, huh? Please watch what you're talking. Okay. Okay. It's all right. I'm on the. Okay, fine. I'm not telling my age. Okay. So 60 is all right, man. 60 is not old. So 50 to 60 is the age where people have just settled their children. And now the time you must see all these foreign trips. You see 60-year-olds having so much more fun than you Gen Z guys. Okay. They are all running around and enjoying the water parks and the rides in the big roller coasters. All right. So 60 is not old. Okay. 60 is age when they want to have a proper vaginal anatomy and a good pelvic floor. Okay, so we'll not say leave for them. Old, debilitated women who cannot withstand a major surgery. Okay. You come and become my PGs, and we'll discuss more. So, a woman with a prostatic valve and on warfarin treatment for anticoagulation is now pregnant. What is the advice given to her in regard to anticoagulation management? She is pregnant with a prostatic valve and she's got warfarin going on. Now, warfarin cannot be given in the first trimester. It is a teratogenic drug. Stippled epiphysis, nasal hyperplasia, all of this can happen. So, warfarin not given. So, first trimester, that is till 12 weeks, I will keep her on low molecular weight heparin. From after 12 weeks, we will start the warfarin till 36 weeks. Yes, I will give her the warfarin. And again, after 36 weeks, till delivery is planned, we can give the low molecular weight heparin again. Why? Because warfarin has got much better action. Warfarin has much better action of anticoagulation, and we can keep the PT-INR, the INR can be kept around 2.5 to 3 easily, and we can get the desired results. But when we stop warfarin, it takes around 4, 5, sometimes 6 days to wash out of the body. Half-life is very high. So around 36 weeks, I'll stop it because she may go into labor at 37. So I'm not going to take the risk. So 36, I stop it. And if she goes to labor in 37, we know that the warfarin effect would have gone off. So we do continue the low molecular weight heparin after 36 weeks. Because even if she's, suppose I'm planning to induce, with these patients, I don't wait for a spontaneous onset. If she's, let's say, having this replacement, so we'll not go much beyond 37 or maximum 38 weeks. So I'm going to induce labor at 38. So one day before or 2 days maximum, I'll stop the low molecular weight heparin also, because low molecular weight heparin, if you stop within 6 hours, the effect will die off. So that's why we have a much better control with the low molecular weight heparin. That's why we keep in the last few days before delivery, we keep low molecular weight heparin. This one, I think you've read it many times, but still. Okay. Okay, Dr. HRX agrees with 60 years is not old. Okay. According to the recent updates of the MTP Act in 2021, March, I think this act, the first act, the MTP Act was in 1971, and in 72 itself there was an amendment. And the latest amendment, they'll ask you, it is 2021. It says now that you can do MTP till how many weeks? You can do till 24 weeks. Okay. So yes, from 20 to 24 weeks, they keep saying that how many practitioners? You need two doctors to opine. Yes, there are two doctors who are taking the opinion, who are making the opinion. So that will make sure that the patient will have a better termination and with good results, and there'll be lesser complications. So two doctors, two brains are better than one when there is a big baby to get an abortion done. Right. So if there is a contraceptive failure only till 20 weeks. Um, yes, I'm not very happy writing this. I have my reservations because a lot of people still say 24 is fine for contraceptive failure, but PNDT people are very strict. They are saying only till 20 weeks. So we have to follow the law. And most of my friends who are teaching also are saying that, I've asked my forensic friends, and they also keep saying that, no, sir, you don't say 24. Contraceptive failure is 20. So yes, I'm under influence of my friends also. So I'm going to stick to 20 weeks. And a lot of institutes, by the way, are following 24 weeks. And I'm not taking any names here because I'll get into trouble. So yes, 20 weeks is what you do contraceptive failure. But there is no upper limit. That is what is very clear. 20 weeks, the contraceptive failure is 20 weeks. 20 to 24 weeks, you can do abortion. But that is for non-contraceptive failure. Like there's an anomaly which you see. But now, let me make this very clear. If you have ultrasound showing a cardiac defect like PST in the baby and the pregnancy is 23 weeks, you can do an abortion. But after 24 weeks, at 26 weeks, suppose you see a VST, you cannot abort because that's not a life-threatening anomaly. The babies will survive. In fact, there are enough pediatric surgeons who will take care of such defects and the baby will be absolutely fine. So if there's a defect before 24 weeks, like there's a Down syndrome, you diagnose a Down syndrome at 24 weeks, 20 weeks, 18 weeks, 22 weeks. So when there's a Down syndrome, you diagnose, let's say, confirmed by an amniocentesis and the results come by 23 weeks, go ahead and do an abortion. But if there's a Down syndrome at 26 weeks, you cannot do an abortion because Down syndrome babies will survive. So be very careful. When you say from 24 weeks onwards, also now we can do abortions for anomalies. There is no upper limit for abortion for anomalies. That is for something like anencephaly, right? There is a anencephaly which is not viable with life at all. So when there is anencephaly, you can do an abortion, but you have to keep a gynecologist informed in that, a pediatrician who will give an opinion, a radiologist will give an opinion, and then a person appointed by the government in the board. So there will be a board of 4 people who will decide that yes, this pregnancy will not continue, and it is ethical that we go and do an abortion for this one. Yes, there is no upper limit for abortion if there are life-threatening anomalies, but not for something like a VSD. Yes, before 24 weeks, a mother can get an abortion for a healthy baby also. Yes, we know that. And anomalies, which are mild anomalies, and the mother is not comfortable, the parents are like, why should I take a baby who's got, let's say, achondroplasia, he's got a short stature. Yes, we'll go ahead and do an abortion. Right? We'll go and do. But only life-threatening anomalies after 24 weeks. I hope you know that difference. Okay. All the following, okay, all the following regarding non-scalpel vasectomy are correct, except hematoma in up to 5% of patients may occur. Yes, any surgical complications can be there in a vasectomy also. Non-scalpel vasectomy, please, before I tell you more details, please promote non-scalpel vasectomy amongst all your relatives, your friends who are married and have 2 children. Please go ahead, even if some people want a sterilization after 1 child. So please promote this because it's a much safer operation versus a tubectomy. So many women have died in tubectomies. You know that, and I know that. But vasectomy, the complications are the least, and it's a OPD procedure done under local anesthesia, and there's no cut on the scrotum. There's just a stab wound. So yes, go ahead and promote that, and the government gives money also. So more money than a tubectomy. So 1100 to the patient and 200 to the motivator. And in a focus states, non-focus state is 1100 and 200. In high focus states, it's up to 2000 rupees. So hematoma is up to 5% of patients. Sexual function following healing is really affected. So we have to tell the wrong statement, right? So this is a correct statement. This is correct. This is correct. Sterility immediately after vasectomy. This is the wrong statement. Recanalization possible is correct. We can do a surgical recanalization later. The success is not very great. I would say 30 to 35% is the re-anastomosis success. My surgeon friends might not agree. They may say up to 50%. But re-anastomosis of tubectomy is up to 80% successful. Vasectomy, 30-35% is what is the trend, what people answer. Some people say up to 70%, 50% also. So sterility is not immediately after vasectomy. This part you guys know well. If I show you this picture, you can understand. Suppose I've done the vasectomy here. I've done the, excuse me. Suppose I've done the vasectomy here. Then the part distal to this, yes, this part, distal part here. This part will have sperms. This part will have sperms for almost 3 months. That's why this question keeps coming in your exams, that for 3 months or for 20 ejaculates, 3 months or 20 ejaculates, the person has to take an alternative contraception, because that's the time taken for the sperms to die and the sperms to get washed out in a ejaculation. So yes, it's 20 ejaculates by Williams Obstetrics. So that's the reference book in Obstetrics and Gynae, and that's the reference book for contraception details. Also, I know your PSM book says 30 ejaculates. In fact, that was my PSM book also when I wrote my entrance exams when I got into JIPMER. Yes, we also remember that. But I'll have to stick to Williams Obstetrics because that's the bigger reference book, and we do the procedures of sterilization. I'll have to stick with that. So I've not seen people asking you choice between 20 and 30. They'll either ask you 20 or 30. But if they ask you between 20 and 30, I would want you to mark 20. All right, because that's what is in Williams Obstetrics. And a lot of people are now teaching 20. Okay, so we'll stick with that. 20 ejaculates or 3 months, whichever is earlier, obviously, because 20 ejaculates can happen before 3 months are over. So whichever is earlier. Once this time is passed, then the gentleman comes to us. He gives us a sample, and in the sample, I must prove azoospermia twice. Yes, you must prove the azoospermia twice. Then only gets a certificate that he's sterile. Then he can apply it to his hospital wherever he's done the vasectomy. He gets the money from the government, and yes, that incentive is only after he's proven sterile by a semen analysis, which is after this time is over. Okay. Now in PSM also 20, is it? Thanks, HRX. I'm so happy if you said that. I'm going to say that now because in one online PYQ series, when I was talking on PW MedEd, and that time somebody told me it is 20. So I'm going to use your reference. Thank you so much. Okay. So yes, I should be reading my PSM books more often now. So drug for medical abortion. Drug for medical abortion, when we do, that is done till 9 weeks. If you do till 9 weeks, it is going to be 95% successful. If you do till 7 weeks, it is going to be 99% successful. So when you give mifepristone, it's going to kill the fetus. Misoprostol is going to expel the fetus. Mifepristone is an anti-progestin. It kills. It's in milligrams. It's an oral tablet. So it's all of these are 200. So which is the misoprostol? Misoprostol is in 2. That is, there's only one has misoprostol. That's the answer then, right? 200 and 800. So yes, mifepristone is oral. Misoprostol is vaginal. All right, don't do this mistake of saying vice versa. Don't say that misoprostol is vaginal and oral is misoprostol. Oral misoprostol may work, but it's going to cause terrible gastric side effects. Even 200 cause a lot of gastric intolerance and vomiting and cramping in the abdomen. So please don't do the otherwise. All right. Okay. I hope you guys can all hear me, but I'm just trying to switch the audio source. Give me a moment, please. Yeah, I hope you can hear me well. And let's get back to work. You guys are just answering right. Chalo, aage badhte hain. A young girl with complaints of not attaining menarche presents with periodic abdominal pain to the hospital. On examination, the following presentation image is seen. What is the likely lesion the girl is suffering from? So yes, you can see that the girl has not attained menarche. So when is it called primary amenorrhea or delayed cycles? Means the same, guys. Girl never having periods is primary amenorrhea. So when do you call it primary amenorrhea? At 5 years? No, the girl is only 5 years. That's not the age for her periods. So that's why when you say delayed cycles, it is same as primary amenorrhea. But you keep getting confused. When I ask you primary amenorrhea, a lot of you in the classes which I take live, you get confused. So please, primary amenorrhea is same as delayed cycles. So if a girl doesn't get periods till 13 years, it is delayed. But yes, if she's got some breast development and there is pubic hair, okay, we can wait for another 2 years because she's got some development. She's coming a little late, it's all right, no problem. So with pubic hair and axillary hair, I can wait till 15. Without pubic hair and axillary hair, it is 13. 13 and 15. Don't keep saying 14 and 16. These are old, age-old concepts, okay? 13 and 15. So yes, when a girl is not getting periods and she comes to me saying she's got periodic abdominal pain and I see there's a hymen which is bulging like this. So that is what is a imperforate hymen. Okay, bathroom cyst nahi hai, Gartner cyst is in the vagina, septate uterus is not seen like this. So yes, of course, you knew the answer to this one. So I'm just trying to show you a video of my hospital, St. Stephen's Hospital, where this surgery is being done. My junior doctor friend, he was doing this procedure. And you can see that we're doing a cross shape, a cruciate incision. And yes, this is that patient. Yes, I've seen this picture being used in many other forums. It's all right. It's okay. It's the picture of a surgery done in my hospital, but we are not taking it to heart. Sometimes we also will take some pictures, but this is a girl who did not get periods till 16 years of her age. So almost 2 liters, 2.2 liters of menstrual blood came out from this lady. So we do a cruciate incision. Have you ever thought, why don't we do a straight plus sign kind of incision? Because if I do an incision like this, yes, if I do an incision like this, if I do a plus shaped incision, the urethra is here, guys. The urethra will get hurt. The incision might just get go and involve the urethra. Okay, that's why we don't do it. Chalo, let's move on and see something else. What are the common obstetric gynecological condition where this procedure is done? Okay, you can see that this is the common iliac artery. Then you're seeing the internal iliac artery here, and you're seeing the posterior division here and the anterior division here, and the anterior branch of the internal artery is lift up, and that is now being ligated. Can you see there's a suture here? So this is the internal iliac artery ligation procedure. When you're doing an internal artery ligation procedure, can be done for DUB after a hysterectomy. Uh, Mind you, I'll just take out this hysterectomy. There's no uterus, there's no DUB, all right? So, um, I think the choice meant was too much of bleeding after hysterectomy. There's a pelvic bleeding. So please pardon the choice. Atonic PPH is the answer. You know that, okay? Recurrent bleeding from a CS cervix, you can do internal artery ligation, but it's too drastic a procedure. I'm not going to do that. Yes, any bleeding in the pelvis, you can go and ligate the internal artery eventually, but we don't do it for such small reasons. CS cervix, we see hundreds of cases. Most of them get stopped by the tranexamic acid, or for some, we can put some packing, and most of such bleeding will stop. So any bleeding in the pelvis, you can do internal artery ligation eventually, but mostly it is done for the atonic PPH, which is not responding to my drugs, and then not responding to the balloon tamponade or the Belin suturing if it is not. So before I do a hysterectomy, I go ahead and do this internal iliac artery ligation. Right. So what do you guys? Okay, fine. The branches of the anterior division is short gills. Yeah, thank you for keeping that mnemonic. Superior gluteal, iliolumbar, lateral sacral, or you can say Shubman gills also. Yes, the current heartthrob of the country. Right. So that is internal artery ligation. A patient presented with bleeding per vaginum, regular uterine contractions, a tense, tender abdomen on palpation. A blood pressure is high, 150 by 100, cervical dilatation of 5 centimeters with full effacement. Fetal heart rate is 144 per minute. What is the likely diagnosis? So yes, we've already discussed this a little bit earlier in the discussions today, and this is tense with high BP. Remember, abruption is classically associated with hypertension. I mean, almost 90% or more cases of abruption we see in relation with hypertension. Okay, so abruptio placentae, we discussed about this. I think I'm going to skip more details right now. Let's go and see the next question. A 47-year-old patient presented with a uterine fibroid with menorrhagia and is planned for a hysterectomy. Okay, at 47 years, you can do a hysterectomy. Yes, keep the ovaries. Till 50, keep the ovaries. No, 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 no. You're not going to say a oophorectomy at 47. Not at all. If the ovary is healthy, it has got function till 50 years and even beyond, some people say. It's got the femininity to take care of and the immunity to take care of. All right. What people do in private practice is no discussion in ethical forums. Yes, people would take out do a hysterectomy at 40 and take out the ovaries. अरे क्या करना है अभी तुम्हारा तो hysterectomy कर रहे हैं तो we'll take out your ovaries also. So that logic doesn't work in ethics. The ovary has got a function till 50 years and even beyond. So till 50 at least you cannot take out ovaries. So you do a hysterectomy only. Fine. Okay, something very close to my heart. So I told you, don't take out ovaries. And now this patient planned for a hysterectomy. Anesthesiologist classified her as a moderate risk in view of a severe heart disease. What procedure cannot be performed? This is a case of a heart disease. How do you do a hysterectomy is what is asked in this question. Non-distant vaginal hysterectomy. What is the meaning of this? There is no prolapse, but still a good vaginal surgeon can go ahead and do a hysterectomy from below, from the vagina also, even if the uterus doesn't have prolapse. When the uterus has a prolapse, it's an easy vaginal hysterectomy. But even in a uterus which is not descended, there is no prolapse, we can do a vaginal hysterectomy. So we can do vaginal hysterectomy. It is not a contraindication. Yes, for fibroids also we can do. We can morcellate the fibroid from below and take out a uterus. Some of my surgeons in JIPMER, my teachers, they have some absolute brilliant surgeons. Some of them are maverick surgeons also. So what I've learned from them is like priceless. What I've learned from my professors back at home, and these guys could take out anything out from the. They could do radical vaginal hysterectomies. I mean, I'm sure a lot of people still do it, but radical vaginal hysterectomy was something which was landmark surgery, which we saw as postgraduates. So you can do vaginal surgeries even for a fibroid. So that is not a problem. You can go ahead and do total abdominal hysterectomy. You can do for this patient. Total laparoscopic hysterectomy is what you can't do. Subtotal abdominal hysterectomy is an outdated procedure. We don't do it much these days. Okay, we don't do it much these days. So we will say it is a total laparoscopic hysterectomy as the choice, which should not be done. Right. So when we're talking about this, please remember, when we're doing a laparoscopic procedure, the problem with the laparoscopic procedure is that the patient will have a distended abdomen, and a distended abdomen will make the diaphragm movement a very difficult thing. And because of the poor diaphragmatic movement, the patient will go into CO2 retention during surgery. So I don't want those complications to happen in a patient who's got a heart disease. So any patient who is in a laparoscopic procedure may have a compromise and may have a retention of CO2. That's why the anesthetists keep fighting with us that Dr. Vich, don't give it too much of a head low position, the Trendelenburg position. Can you do it with a straight patient? I say, nahi yaar, I want the bowel to go up. So give a little bit of Trendelenburg at least. So we keep having our arguments. But in a case of heart disease, there's no argument, because whatever little bit of compromise happens is bad for the heart. So we cannot do hysterectomy with a laparoscopic procedure when the patient has a heart disease. So yes, problems with the laparoscopic surgery in a heart patient: reduced cardiac output because there is increased abdominal pressure, which causes reduction in the cardiac output by 30%, almost 30% reduction in cardiac output, and there will be retention of CO2 also, and there will be increased afterload on the heart. Okay, and the Trendelenburg position will increase the venous return, because the head low position, when you keep the head low, there'll be more venous return and there'll be more work expected out of the heart. So that's why the heart can go into failure. I will not do a laparoscopic procedure. Right. Um, Woman during labor presented with a persistent occipito-posterior position. Favorite question these days. Okay. Manual rotation was tried, but it was unsuccessful in what type of pelvis? Look, INICET, AIIMS people were the first ones. Now it is INICET. Excuse me, guys. Excuse me. So, uh, occipito-posterior, what do you do? That's the question which was classically coming when it was the AIIMS exam. I remember teaching this long time back. And now NICT and an MC exam. These two exams are very fond of asking the most common mal position, which is right occipito-posterior. And when occipito-posterior comes into the pelvis, it rotates and becomes occipito-anterior 80% of times, it delivers. 15 to 16% of time, it stays occipito-posterior and delivers as a persistent occipito-posterior, which is a face-to-pelvis delivery, and that happens in an anthropoid pelvis. So yes, there is no rotation possible in an anthropoid pelvis. So that's why the answer is anthropoid. Look, I'll just show you here. You'll not understand without the pictures. So if you see the gynecoid pelvis, it's a nice round pelvis. So if there's an occipito-posterior here, let me not do that. Let me do this. If there's occipito-posterior, the arrow is the occiput. This is occipito-posterior, and this is occipito-posterior. Of course, in the platyploid, you'll see the face. Platyploid, you see the face presenting part. Face will deliver generally in mento anterior face will deliver. Now we are talking about the other three. The most common pelvis is gynecoid, second most common pelvis is the anthropoid, and in the anthropoid the side walls are parallel, so this rotation cannot happen. That rotation of the head from occipito-posterior to occipito-anterior cannot happen, so no rotation possible. So that's why it stays occipito-posterior and it delivers by face to pubis. Face to pubis delivery. Please don't say face to pubis is seen in a face presenting part. That means you've not read obstetrics at all. So phase 2 pubis happens in a persistent occipital posterior which delivers as occipital posterior. Right, guys? So yes, android pelvis, it will rotate partly. Yes, it will rotate partly to occipital transverse, and the front walls are narrow. The front walls are narrow. So rotates to occipital transverse and stops. So what you can do that? You can do a manual rotation and a forceps extraction. Yes, you can hold the head and rotate it manually to occipital anterior and take your hand off and immediately apply forceps. And then you can pull this baby out without any problems. Manual rotation, forceps extraction. A lot of our doctors or seniors, we've learned that we can do a forceps rotation and a forceps extraction also. But nowadays, a lot of people are not very happy doing forceps rotations. It is legally accepted even now. All right, please, it's a safe procedure in accepted hands, and please, forceps rotation and manual rotation are both still accepted procedures, right? Like breech vaginal delivery is an accepted procedure. The last exam, in the last exam, which was the NCA exam, they asked you a breech question. So breech will be asked in the exam. Don't think breech won't be asked. And breech vaginal delivery is still legal, and don't say breech is a cesarean section. What happens in practice? In practice, a lot of things keep going to the comfort of the obstetrician and how much of risk the obstetrician is willing to take. The prior practice has a lot of litigation, and even general practice, even in government practice, litigation can happen. But the risk taking in prior practice is much lesser. So we will follow proper obstetrics, and in your exams, those who are finally students watching this, please remember we will still ask you breech vaginal delivery. MD students also will be asked about breech vaginal delivery. So it is still valid. So man rotation and forceps rotation are still valid questions. Right, guys. Sorry, guys, asking me now. So, but in persistent occipital posterior, it's android. No, I can't see. Uh, some discussion amongst you guys happen. There's a heart sign here which I can't see. What you've written here. That yeah, anthropoid. Yeah, persistent occipital posterior is anthropoid. Did I say something else? Anthropoid, persistent occipital posterior. All right, so let's see the next question. During an antenatal visit of a pregnant lady of 20 weeks, the fundal height is only 16 weeks. An ultrasound shows no amniotic fluid. Which abnormality is likely to be the cause in the fetus? Yes, amniotic fluid is because of the urine output of the baby. After 20 weeks, the major amount is made by the urine, fetal urine. Of course, also from the transmembranous, also there should be some amount of fluids coming into. So we say look for renal anomalies, right? So when we see this, you should see that the contribution plus green I've written urine is 1000 ml by the baby every day. Lung secretions is 350 ml every day. What is reducing the amniotic fluid daily? Fetal swallowing, 750 ml gets swallowed, and intramembranous fluid transport across the fetal blood vessels and on the surface of placenta, 400 ml will also get transported back into the circulation. So that's why the amniotic fluid will have major contributions in 1000 ml. Of course, quite a few things push in the fluid, quite a few things will take out the fluids, but the major contribution is by the urine output. All right, you know these things well. Let's see the next question. A pregnant lady was given an oxytocin bolus for induction of labor, and the nurse instead of by the nurse instead of a infusion. There's a mistake. Oxytocin bolus should never be given. You know, you should never push in IV oxytocin. Look, in high doses, they can be a problem, and if you give bolus, they can be a problem. So always oxytocin is given as an infusion. That's why when we say when the baby delivers and the anterior shoulder delivers, we give oxytocin IM 10 units. You can give it slow IV also, but we generally give it IM. And we've given, you know, in a diluted form, we give it slow IV also. But you cannot just push in oxytocin. When you push in, there can be sudden, retention of fluid, and there can be pulmonary edema, and there can be hypotension. So sudden hypotension which can happen because of the patient having a bolus oxytocin. The hypotension is the reason because of which the patient may collapse also. So please do not give oxytocin as a bolus injection, always slow IV or in an infusion form. A primary grader underwent a normal vaginal delivery conducted by an intern. I did not like this question. Huh? This question came, I think it was a INICET or I think it was an MCA exam, 2022. There are 5 exams, so I'm a little blurred, but it came. I've read this question. I was really upset. I'm registering my protest. Whoever made this question, it should be delivery done by a untrained personnel. Except it can happen. Interns are nowadays reading. Yes, you're reading so much for becoming interns, and while internship, you're reading for postgraduate entrance, and you guys have worked a lot. So I don't like this question. I've registered my protest. Okay. A patient has minimal bleeding but out of proportion shock, and eventually she died. So yes, an intern, supposing that he's not well trained and he was doing the control cord traction and it was not done properly, he just pulled the cord straight away and it caused an inversion. Inversion causes sudden pain and that neurogenic shock can kill. Yes, the bleeding also can kill, but there is minimal bleeding and out of proportion shock. So there is a event. There is an event that the person who was doing delivery was not a trained person, and that's why this inversion happened. So when in this kind of story is given that it's a delivery by an untrained person and there is a death because of shock, I'll say it's an inversion. If there is a lot of bleeding and there's a death, I'll say it is PPH. But there is no bleeding and the delivery is done by, let's say, Dr. Prassan Sir, a senior obstetrician, head of the department. I do a delivery and everything was fine. There was no PPH. And I did a control cord traction. The plasma came out fine and the baby was healthy. I showed the baby to the mother. The mother smiled and she was so happy. The baby's been taken care of by the nurses and the pediatrician. And I'm just, taking the placenta out. After the placenta out, I'm doing the episiotomy under local anesthesia. I'm just trying to keep the lady happy, congratulate, chit chat. And suddenly the woman collapses. There's no PPH. The woman suddenly collapses and she is dead in 5-10 minutes. I've done the CPR. I've called my friends from the ICU. The crash team is here. The blue code was done. We do everything and the mother dies in spite of a best of efforts. Suddenly, out of no reason. That is amniotic fluid embolism. So the question is very clear in the exam. But when it is recalled by a lot of students and it is there in so many other sources that you people keep getting confused. So if it is a normal delivery, no PPH, nothing is wrong and the woman suddenly dies, that's amniotic fluid embolism. It's a catastrophe. More than 50% women will die. In fact, I've seen hardly anybody surviving. That's what is sad. But yes, it has to be a proper history. This patient is having an inversion. Okay. Okay, I think I already told you amniotic fluid embolism. So you asked me that question, so I've told you that. A patient underwent a radiotherapy for cancer cervix. Which organ in the pelvis is more radiosensitive? So if you give radiotherapy, the ovaries are going to get fried up. Yes, the ovaries are the most radiosensitive. What did I say? Ovaries, normal ovaries are very radiosensitive. They'll get fried up by the radiation. But if there is a ovarian cancer, ovarian tumor, they are extremely radio resistant. So normal ovary, radio sensitive. Ovarian cancer, radio resistant. So none of the protocols of management of ovarian cancer involve radiation. There is an exception to that also. The only radiosensitive ovarian tumor is the dysgerminoma. It vanishes. The dysgerminoma vanishes with the radiation. The classical adage was that radiation treats dysgerminoma so well. The dysgerminoma vanishes with radiation just like the snow vanishes when the sun comes up. That kind of a result is there with the radiation. But that's only for dysgerminoma. Otherwise, ovarian tumors are radio resistant. Yes, over is the answer. Let's move on. Please remember, all you girls watching this, please remember, if you, yes, I'm getting personal, but if you have any, even if you have a head and neck ultrasound, head and neck x-ray done for, let's say you've got a sinusitis, please cover your abdomen with a lead shield. It is there in all x-ray rooms. All x-ray rooms, wherever you go, they'll have a lead shield. Please cover your abdomen and prevent the ovaries from getting radiation. Okay, a lot of young girls have come to us because they had road traffic accidents and they had a fracture of the femur, a fracture of the leg, and they are getting radiations done, but they're not covering their abdomen. The personnel who is doing the x-ray should be telling you that, but you should be aware. You're all doctors, tell your friends also. Where is the SRY gene located? Okay, the sex determining region Y. That is the region which tells that if this Y chromosome has the SRY. So Y chromosome is present, then there'll be testes. Absent of Y chromosomes makes the ovaries. Okay, so this is on the Y chromosome. Is it on the short arm or the long arm? The short arm of the Y chromosome. The long of the Y chromosome has the azoospermia factors. Azoospermia A, B, and C. Those are the azoospermia factors. Okay, so the short arm, this one, has the sex determining region Y. All right. So a nulliparous 29-year-old lady presents with infertility. On examination, the uterus is felt to be normal size but is retroverted and fixed. Also, there is tenderness in the posterior vaginal fornix. So 29-year-old lady, nulliparous, infertility, and there is retroversion, but it is a fixed retroversion. Retroversion can happen to a lot of women who are not not all women are very physically strong, and they're not doing abs, and they are not having a very good abdominal tone. So a loose round ligament can cause the uterus to be retroverted. So this is the posterior vaginal wall. This is a penis which is leaving the semen in the posterior vaginal fornix, and this is the uterus which is anteverted. So an anteverted uterus will keep the cervix in the vaginal pool, and when the semen is released, the cervix will pick up the sperms. Now if the uterus is retroverted, see, the vaginal pool is missed, the cervix is in the anterior fornix. So that's why infertility is there with retroversion. See, retroverted uterus can cause infertility, but that can happen to normal women also, retroversion. But if it is a fixed retroversion, you're not able to correct it, that is because of endometriosis, because endometriosis classically has adhesions. So adenomyosis is generally older women. This is an older woman who are multiparous. I mean, we are talking about black and white. I remember I told you multiparous women. Endometriosis, yes, is the answer. Fibroid uterus is not the best answer for this situation. Ovarian malignancy, again, retroversion of the uterus is classical endometriosis. Which of the following most common cause of abnormal uterine bleeding is seen in pubertal girls? Pubertal cycles are anovulatory. Remember, the first few months, the cycles are anovulatory. So yes, anovulatory bleeding. Anovulatory bleeding is the reason of a woman having. You have been told this numerous times in the app and in many discussions with me. Ovulatory cycles regular, anovulatory cycles irregular. Ovulatory cycles painful, anovulatory cycles painless. So yes, when a girl is getting into her system of menstruation, first few cycles are anovulatory and they're irregular, please don't bring the girl to the obstetrician or the gynecologist, because too many drugs given for this. This is self-limiting condition until she's having heavy bleeding. If she's having irregular bleeding, it is more or less taken care of by the mother herself. She'll say, okay, it's fine, my dear, you'll get okay in a few months. But if it doesn't get okay, if she's having still irregular cycles, bring her to us. It's 1 year or 2 years of puberty, bring her to us. But if it is just first 6 7 months of getting periods and the irregular, reassurance is what we do. Of course, if the bleeding is a little heavy, we can give her NSAIDs that will take care of the pain and also of the bleeding. But anovulation, right? It can be many other reasons. I'm not saying bleeding disorders and malignancies don't happen to young girls. Can happen. We're talking about normal, common things when we're talking about MCQs. Okay, not the rare things. A semen analysis shows absent fructose. Yes. Which of the following is the probable cause? We discussed that, I think, when the first question about the cystic fibrosis patient, we discussed that when the patient is having a seminal vesicle problem, there will be lesser volume and there will be no fructose. So absent fructose, we have to think in terms of absent seminal vesicles. We discussed that, right? So we'll move on and save time. A 19-year-old girl presented to the clinic with complaints of primary amenorrhea. Okay, another question has come today. Normal sexual characteristics are noted, and the lab test come out as FSH is normal 2 to 6, LH is normal 1 to 6. LH and FSH is normal. Young girl is not getting periods. She is now 19 years with a normal karyotype 46XX. What is the most likely diagnosis? So Mullerian agenesis A looks like the answer here. Androgen insensate syndrome is a boy, looks like a girl, a pretty girl in fact, but this boy will not have, this boy who's looking like a girl, so this girl will not have pubic hair. So androgen insensitivity. So please remember, any question on intersex, always look in the information. They'll tell you normal pubic hair or absent pubic hair, or sometimes they'll say scanty pubic hair. It's all trying to tell you that the pubic hair is not formed, that means androgen production is not good. So then you think in terms of androgen insensitivity syndrome. All right. So this is definitely not androgen insensitivity syndrome. It is not gonadal dysgenesis because the LH and FSH will be very high. Gonad is not working, but the brain is working. FSH will be very high. Kalman syndrome, the LH and FSH will be low. LH and FSH is very low because it's a hypothalamic amenorrhea, no pituitary stimulation. So yes, I think most of you got this answer correct. Yes. All right. Uh, I'm not able to get your question, my dear. Kaushik. In question related to MTP, the question asks time limit for a registered medical practitioner, which means one RMP. Oh God. See, first of all, it's not RMP. It is going to be a gynecologist with experience. So if they ask when can a medical practitioner do MTP? Yes, that's all. Don't try to find out, variations in the information given. When can MTP be done? They're not saying by one. They're saying when can MTP done by a single doctor? Like that, if they ask specifically, fine. When can MTP done by a registered medical practitioner? They are not saying two registered medical practitioners. Please don't get into all this confusion. What I gave you information is for the gynecologist who's trained and can do MTP till 24 weeks. Yes, if he's doing the MTP till 24 weeks, after 24 weeks, he'll take a opinion of another friend. That's fine. Please don't try to get into, the exam questions are very clear. The kind of question you've given me is precisely what the guidebooks confuse you. They'll find out quips in the information given and they'll try to confuse you. I, don't get into that. Yes. Which type of placenta is not seen in a twin pregnancy? Look, this is about the classification of the twin pregnancy. Twin pregnancy can be two placentas with two amnions. So, two placentas, two amnions is seen in dizygotic twins. But it is also seen in monozygotic twins, which split before 3 days. So, we always say in monozygotic twins, remember less than 3 days, 4 to 12 days, 4 to 8, I'm sorry, 4 to 8 days, 8 to 12 days, and after 12 days. So yes, if it is splitting before 3 days, we say it is dichorionic diamniotic. Splitting after 4 to 8 days, it is monochorionic diamniotic. And after that, 8 to 12 days, it is monochorionic monoamniotic. And after that, it is conjoined twins because the embryonic plate is already formed. So if the cell mass split after 12 days, then it's going to be a conjoined twin. Now, this is in monozygotic twin which you're discussing, and in that also 30% of monozygotic twins will be dichorionic diamniotic. So what am I trying to tell you here? That whenever you have a nomenclature for twins, always mention placenta first. Remember, say placenta first. Dichorionic diamniotic. Next, monochorionic diamniotic. Next, monochorionic monoamniotic. But if you say amnion first, you will do a wrong nomenclature because you will say diamniotic dichorionic. First one is fine. Second one, you're going to say monoamniotic dichorionic, which is not feasible. So monoamniotic dichorionic can never happen. That's why I always say placenta in the nomenclature, you'll not get confused. So yes, that's the question given here. The choice C, a patient having a monoamniotic pregnancy and two placentas. A monoamniotic pregnancy with two placentas is not possible. So yes, that's the answer here. Okay, this cannot happen. So that's why I always mention chorion first in your nomenclature. You will not get confused. This is a nicely mixed up kind of a question, and to confuse you guys, always remember the chorion first, the placenta first in the nomenclature. You will not get confused. Whenever this question comes, just revise, just write. Take no time for you to write. Dichorionic diamniotic, monochorionic diamniotic, and monochorionic monoamniotic. This is the way it goes. So you cannot have one sac with two placentas. You cannot have one amnion with two placentas. You cannot have that, isn't it? So that's why the monoamniotic dichorionic is not possible. Which among the following is the natural form of estrogen which is the most potent? Estrogen are E1, E2, and E3. E1 is the estrone. E2 is the estradiol, which is seen in the young women. So young women have the estradiol, and that is the answer to this question. E2, estradiol. E3 is estriol, and that is seen in pregnant mothers. So yes, the answer is estradiol, which is the most potent form of estrogen. In women who are postmenopausal, you'll see more of estrone, which is not so potent. That's why women have problems of estrogen deficiency. And in pregnancy, you have more of estriol, right? So that's a simple question. You knew that answer very well. What is the antigen present in the HPV vaccine? Remember, HPV vaccine 16 and 18. 16 is most common, 18 is the most malignant. You know that. But how do they cause the effect of causing the dysplasia? That is because the E6 and E7 oncoprotein. What is the significance of the L1 capsid? The L1 capsid is the one against which the vaccine is made. The vaccine, the Gardasil 9, the Gardasil 4, and the Cervarix, all these vaccines are made against the L1 capsid, the capsule of the HPV virus. What is the correct dose of antenatal steroids which we give for lung maturity? Now that's the question which all of you know the answer, but you know also that this will come in the bulk easy questions of any exam, and that is dexamethasones. Remember, always we say dexamethasone is the question which is coming in exam. So dexamethasone is 6 milligram 12 hourly 4 doses. Is that given here? Yes, that's the correct dose. Beta methazone is not 6 milligram, dexa is not 12, beta is not 12 hourly. If this was written beta 12 milligrams 24 hourly, that would have been a correct answer here. So that would have been correct. This is also wrong. So please do not choose between beta and dexa. A lot of you will say that government supply kaun sa hai, ye zyada sasta hai, ye zyada mehenga hai. We are not involving you in that discussion at all in the exams. We'll ask you beta methazone dose, you say 12 milligram 24 hourly. We'll ask you dexamethasone dose, 6 milligram 12 hourly 4 doses. So you will not get into all the discussion which is there in the rounds when we are trying to see which one is better. There was a lot of talk of DEXA being the best, then beta became the best for good 8-9 years. And now Williams is very clear that beta and DEXA are both equally effective. So you're not getting into that discussion. For you, both are equally good drugs, and DEXA is the dose which is generally asked in the exam. Right. What is the subsequent course of action in the management of a 50-year-old lady who's experienced abnormal uterine bleeding for a duration of 2 months? Please, guys, that is the question which I wanted to include. I'm happy that we have kept this question, guys. Very important. Irregular bleeding in a 50-year-old woman. Dare you say hysterectomy? Dare you say IUCD? And dare you say progesterone only pills for 3 months? Please, I'm challenging you. Guys, if a woman has abnormal bleeding, you have no business of doing any treatment till you know what is the cause, especially around 50 years. So any question after 40 years, even 35 years, I'll say, any woman having, she has 2, 3 children and she's having abnormal bleeding, the first answer a lot of you say is hysterectomy. Or you give progesterones. Arey nahi bhai. First, if a woman is having abnormal bleeding, I want to know the cause. I'll examine the lady. If she's got a vulval, vaginal, or a cervical lesion, no, everything is fine. Then I'll look for an endometrial reason. So I'll go into the uterus and I'll scrape the endometrium. I can scrape it in the OPD, PPL biopsy. I can scrape it in the OT, DNC. I can do a hysteroscopy, get in the uterus and be very sure what I'm seeing and take a biopsy. So I have to do an endometrial sampling. Now this choice can come as endometrial sampling, histopathological examination. It can come as a EB. It can come as a, what did I mix up here? Histopathological examination, EB, or a DNC. Any of these four choices may come. It all means that do an endometrial assessment and then do the treatment, because she might just be having endometritis. You have to give antibiotics. If she's having a hyperplasia of the endometrium, I can treat it with progesterones. If there is hyperplasia with atypia, a hysterectomy is enough. If it is endometrial cancer, I have to do hysterectomy with a staging procedure of doing pelvic lymph node sampling and para-aortic lymph node sampling, and then get to know the staging and then manage the patient. So it depends on what is coming out in the biopsy. This is absolutely simple. Always, this question is such a favorite, and I don't know why you guys keep saying hysterectomy first. Please, when a woman has abnormal bleeding and she's 40 years, it does not mean that she should lose the uterus. That's the thought process, which is the reason why hysterectomy answers are given in a lot of your sources. No endometrial sampling. Okay, chalo. I hope I impressed you enough about this one. Next question. What should be the subsequent course of action of a 30-year-old woman who has been diagnosed with carcinoma in situ of the cervix and no apparent visible growth? You've done a pap smear. The cervix was fine. It looks absolutely normal to me. But the cervix on the pap smear shows CIN3, carcinoma in situ. So the cells on the cervix more than two-thirds bad, CIN3. All are bad, carcinoma in situ. On the surface, there's a cancer because I've done a smear on the surface. Now, what is happening inside? If there are more than two-thirds bad cells, CIN3, if there are all cells bad, carcinoma in situ, the question here, then that is a pap smear diagnosis, which is a screening test. If there is a high grade lesion like you're seeing here, then I want to make sure that it is actually a carcinoma in situ or a CN3. I want to make sure what I'm treating. So again, I'll do a confirmatory biopsy. I'll do a biopsy of the cervix to see if there is invasion or not. So please remember there are three places: CIN3, carcinoma in situ, and postcoital bleeding. For God's sakes, don't say postcoital bleeding, I'll do a pap smear. Please, postcoital bleeding is a symptomatic patient. What is the most common presentation of CS cervix? Postcoital bleeding. If a patient is telling that I'm having bleeding after sex, she's already giving us the major symptom of CS cervix. Are you going to do a screening test or a diagnostic test? Guys, this question has come in INICET that a woman underwent a pap smear. I'm sorry, a woman had postcoital bleeding and a colposcopic biopsy was not having a conclusive opinion. What is the next step to be done? And the next step was a conization. This question has come already in your INICET. So postcoital bleeding, you do a colposcopy. If that is not conclusive, you do a conization. That's the chain of events. And you guys say that post-coital bleeding do a pap smear, which is only 48% to 62% sensitive. It's going to miss the cancer if it is there in almost 40% of cases. So post-coital bleeding, don't say pap smear. So post-coital bleeding, CN3, carcinoma in situ. All of this we are going to say a colposcopic biopsy, and then you have to manage the way it is coming out, right? So, okay, I get a little emotional sometimes, right? Some questions are very, very important. This one, and irregular vaginal bleeding in a woman who is 45, 50 years of age. These are the questions which are regulars in all your exams. Okay, let's move on and see the next one. Which of the following is excluded from the composition of fetal biophysical profile? So it's fetal movement, fetal tone, fetal breathing, which is basically fetal swallowing. Fetal breathing is basically swallowing, amniotic fluid index, and the non-stress test. So all of this is there, but the contraction stress test is not there. So D is not the right answer. Identify the procedure done in this labor room here. So there are two belts. So one belt is non-stress test. There are two belts. So that is a uterine contraction along with the fetal heart rate. What happens to the fetal heart rate in relation to a uterine contraction? That is a cardiotocography. That is a cardiotocography. That's the answer. Right? What is a modified biophysical profile? A modified biophysical profile, the hotshot question these days, NST plus amniotic fluid index. You guys are answering D for this one. Nani here? Postcoital bleeding is not polyp, guys. God. Postcoital bleeding is CS cervix most of the time. Oh, you're asking me yeah, postcoital bleeding is not polyp most of the time. What is the most common cause of postcoital bleeding? Look, most common presentation of CS cervix is postcoital bleeding. Postcoital bleeding can happen because of hymenal tear, can happen because of vaginal tear, can happen because of polyp, can happen because of cervicitis, vaginitis, CS cervix. Please, that's not polyp most common. What is the most common presentation of CS cervix is postcoital bleeding. What is the most common cause of postcoital bleeding? We're not asking that. Yeah, definitely asking you what is the most common cause of postmenopausal bleeding, and that is CS cervix in our country. Yes, in the Western setup, please don't say all over the world. In the Western culture, Western setup, they're very aware of CS cervix. They do screening well. So CS cervix is not in the list. Endometrial atrophy causing senile endometritis. Yes, it's given in INICET Gynaecology. It's given in all their Western books that post-menopausal bleeding in the Western setup, that is, developed countries, only 15 to 20% of the world is developed, guys. 80% of the world is people like you and me. Whole of Asia, whole of South America, whole of Africa is like you and me. And we are the world, guys. We are the world. We are the people who are the poor, the developing and the underdeveloped countries. And that is 80% of the world. So nobody's going to ask you the world instance. Even if they ask you the world instance, the people in the world are like you and me, and we get CS cervix. Why is the confusion in this question so much? Post menopause bleeding in India is equal to CS cervix. I've shown you Indian data so many times. There was this Nagpur study which I'm quoting. Please see Dr. Ramtake's paper, and such a lovely paper it is about post-coital bleeding in India, and 37.5% of patients had CS cervix. That is the most common cause of post-menopause bleeding. So please do not get confused. Endometritis in a senile endometrium is seen in our country. How many interns? Look, how many interns are looking at this? How many of you are writing the exam? Tell me, how many of you seen, each one of you sitting in this lecture, and whenever you see this, how many of you seen senile endometritis? Tell me, if any one of you see. Come, I'm waiting for answers. Come, I'm getting emotional again. Tell me, come, how many of you seen senile endometritis? You keep saying it is the most common cause. Tell me how many of you seen. But each one of you, if you've gone to the gynae OPD, each one of you seen CS cervix. Put a hand on your heart and tell me. Each one of you seen CS cervix. Because if you've gone to the gynae OPD, it's a starking reality. CS cervix is very common in our country. So please don't keep saying senile endometritis. It's a Western figure. Okay? Chalo. Post-coital bleeding, of course, I've told you. Now this is a cardiotocography. What would be regarded as an absolute contraindication for the insertion of a copper-T in a patient? Unmotivated patient. Now, this confusion also there. A woman is non-motivated. She cannot remember taking COCPs every day. She cannot remember coming for a change of an Implanon. She is, forgetful of all these procedures like the natural contraception by Billings method or the calendar method. So when she's not motivated enough, then you can put an IOCD inside and she doesn't have to remember about anything. So it's not motivated for contraception well. It's not that she's not motivated for IUCD. A woman who is not motivated for contraception well, she's forgetful, she does not follow things properly. IUCD is the best thing for her. You put an IUCD inside and fill it and forget it for 5 years. Use Paragard, forget it for 10 years. She doesn't have to remember about contraception. That's the meaning of non-motivated, right? So this, it is an indication we give. Menorrhagia will never give. Irregular bleeding is a contraindication because the commonest side effect. So the answer to this question is B, absolute contraindication. Previous ectopic pregnancy is definitely not a contraindication. Guys, now this is where you're wrong. A previous ectopic is you go ahead and see the contraception booklet given by the Association of Obstetricians and Gynecologists of Delhi and the Indian bodies, FOXY. IUCD will reduce pregnancies, will reduce ectopic. किसने बोला IUCD will cause ectopic? If I give a woman IUCD and tell her तुम्हें ectopic हो जाएगा, you think she's going to take the IUCD from me? IUCD reduces ectopic. It's not a contraindication. So the answer is menorrhagia to this question B. Right. Let's move on. A lot of controversies we discussed today, and please, whenever you have a doubt, just rewind and listen to this lecture again. What is the minimum endometrial thickness on a transvaginal ultrasonography above which you perform a biopsy in a case of postmenopausal bleeding? In a postmenopausal woman also, this bleeding, I think, might be getting you a little confused. Postmenopausal woman is the better question which we wanted to ask you. Pardon for the mistake. So postmenopausal women should never have an endometrium more than 4 millimeters. So anything more than 4 millimeter is bad. So yes, minimal endometrial thickness is 4 and more. So would have been better if it was written more than 4 millimeters. Would have been a better answer. But I'll definitely write this as the answer to this question. A pregnant woman has a fetus with Down syndrome. Triple test done at 15 to 16 weeks will have. It'll have a high HCG. H for high. Remember that. H for high in the triple marker and the quadruple marker, and even in the dual marker. HCG, H for high. So high HCGs in only this one and this one. So alpha fetoprotein will be low, correct? And there'll be low unconjugated estriol. So all of these are low. Yes, so answer is A. So remember, in the quadruple test, we have the inhibin also there. So inhibin is there in the quadruple test. Inhibin IN for increase. Increase inhibin and high HCG. That's how I remember. HCG will be high. Inhibin will be high, and that will suggest chromosomal abnormalities like Down syndrome, this one here. But in quadruple marker, which inhibin is used? That is also a question. The inhibin used is the dimeric inhibin A. Inhibin A is used. Okay. So guys, all of you answering well. Let's move on and see the next one. Next one, yes. Fixative for a pap smear. Absolute information which has to be known. for all doctors. Pap smear, 95% alcohol. It is kept in the Copland's jar. So you make a smear and immediately dip the slide in the fixative. No drying. That was the MCA question, but I'm sure all of you know it, that you should not be drying the slide. You dry the slide, the architecture, the cell's architecture gets dried up, and drying up artifacts will not tell you the cell information as you want it. Right. Primary care came to the labor room at 40 weeks plus 5 weeks gestation for induction of labor. On per vaginal examination, the cervix is 1 centimeter dilated and 30% effaced. The vertex is at +1 station. The cervix is soft and posterior. What is the Bishop score? You thought you will not read Bishop score, guys. Bishop score comes in INICET and it comes in MCA. These two exams are very fond of asking this, and you're writing INICET. Read the Bishop score properly. So I'll help you with this. See here. Primary care came to the labor room with 5 days gestation for induction labor. Per vaginal examination, the cervix is 1 centimeter dilated. See, 1 centimeter dilated is here. And it is 30% effaced. 30% is here. And the vertex is -1 station. -1 station is here. Sorry. Here. And the cervix is soft and posterior. Okay. So that is 1, 2, 3, 4, and 5. So 5 is the bishops for this one. Now, me as an obstetrician, we guys know this in our head, the bishop score. I just did the exercise for you, and the answer is 5. Guys, this is going to come in the exam. You have to know this chart. Remember, there are only 3 things which has the 3 score. 2 things, the consistency in position has maximum 2 score. So with this, and try to make your own discussions, you have to know the bishop score. This chart won't be given, so you have to learn it in your head. Okay, right, guys. What is the most suitable treatment for a 55-year-old lady diagnosed with simple hyperplasia of the endometrium accompanied by atypia? Simple without atypia, complex without atypia is only 1 to 3% cancer. That's why a simple hysterectomy can be done without atypia. A progesterone treatment can be given. A woman with atypia, I'm so sorry, with atypia, you go ahead and do a hysterectomy. It is not cancer. Hyperplasia is not cancer. It's a pre-malignant condition. So simple hyperplasia without atypia is 1%. Simple hyperplasia, complex hyperplasia without atypia is 3%. Simple with atypia is 8%. Complex with atypia is 29%. So it's a complex hyperplasia with atypia and simple hyperplasia with atypia. With atypia, I do a hysterectomy. Without atypia, I can give progesterone tablets to reverse. This is also a fairly common question. All right, keeps coming in the exam. So, guys, thank you so much for patient listening. And we've had a lot of A for which one, my friend? Hysterectomy nahi hai yaar. Hysterectomy with the atypia. I marked it by mistake. You know, I wanted to mark progesterones. I marked it by mistake. Simple hyperplasia with atypia. Okay. Oh. Yeah. Okay. Thanks. I think I read this wrong. Okay. Wait a minute. I'll do this again. Wait a minute. I just read this wrong. I accompanied by atypia. Once again. So sorry. Atypia. Correct. A is the answer. Correct. Without atypia. I'm sorry, I messed it up. So sorry. Without atypia is the progesterone. Yes, I think I read it wrong. This is what happens when you read a question in a hurry. What questions you know well, you make a wrong assessment. So good demonstration of reading a question fast and giving an answer wrong. So pardon for the mistake, guys. Last question I muffed up a little bit. So we'll remember with atypia, you have to do a hysterectomy. Without it, I said this right, but I marked it wrong. So thank you so much, guys. Cancer staging is important. Please understand. Cancer staging is definitely important. CS cervix endometrium. Definitely padke jana. Explain what, my dear? Dr. Patel, what do you want me to explain you? If a woman is having atypia, you cannot preserve the uterus because the cancer chance is high. So with atypia, okay, I'll write simple without atypia. I told that, but yes, now that I did a mistake, complex without atypia. Simple with atypia and complex with atypia. 1, 2, 8, and 29. 1, 3, 8, and 29. So without atypia, okay, without atypia, we can do a progesterone treatment. We can give progesterone, and with atypia, we do a hysterectomy. Right? Okay. Right, guys. Thanks for thanks for patiently listening to me, and apologies for the last question. Guys, so we'll be back for more as always, and it is very engaging to have these discussions, and I'm so happy having these discussions, and we'll be happy if we keep meeting more often, and there'll be these sessions. I think a marathon is coming up, and please attend that, and we'll try to do even more questions and maybe a little bit more theory in the marathon, right, guys? So thank you so much, everybody, and keep reading, do well for exams, and keep informing me of your results also. Bye. God bless.